Hello, ladies and gentlemen. This is your Symposia on Facebows and Articulator, and I am Reza Roudsari. Without further ado, let's share a screen and look at the presentation. Okay, so what I'm hoping to do in the next half an hour I've got with you is to help you become familiar with different types of articulator, and also I would like to go through the concept of taking a Facebook record. So meanwhile, I would hope that I manage to teach you the factors that have an influence on the mandibular movement, and then hopefully you can apply this new knowledge into practice, and possibly I will just touch a little bit onto occlusal disharmony as well. Now, before we get started, I've got a picture of an articulator for you, and I would like for you to guess whether you think this is a fully adjustable, a semi-adjustable, an average value, or a simple hinge articulator. And your time starts now. Okay, anyway, so hold that thought, and then we're going to go into why we need to use articulators. Essentially, use articulators for two main reasons. Either is for diagnostic purposes or in order to proceed with the restoration phase. So when it comes to diagnostic, you could be mounting casts and then bringing them, for example, to likes of me to discuss the case, make changes to the occlusion, plan some wax-ups in the new occlusion. And whenever it comes to the restorative phase, is to try to mimic dynamic occlusion where possible, and also try to restore your teeth into your future planned occlusion. For instance, this is a two-square case of mine. So picture number one, you can see the patient who has suffered localized anterior wear. In case two, or in picture two, I do apologize. We've sent the impressions and a Facebow mount, and the laboratory have done some wax-ups. In picture three, we bring or use the wax-up in order to use a temporary material, for example, ProTemp in this case, in order to transfer what we've done on the cast onto the patient's mouth to double check roughly how things look like and what the occlusion is like. And then in picture four, you can see that we managed to use this information on the articulators to transfer things into the patient's mouth using dental composites. Anyway, so before we get into more depth into articulators, I have to talk a little bit about a dynamic occlusion for you. And essentially, dynamic occlusion is your mandible when it's moving. So when it comes to mandibular movements, you have got anterior determinants of occlusion and posterior determinants of occlusion. And your anterior determinants are genuinely your teeth. So teeth are part of your articulatory system, which are going to guide your mandible to a variety of different directions. And essentially, these are the five main factors which will influence where your mandible is going, guided by your teeth. So that's your incisal guidance, your maxillary plane, the cuspal height of your teeth, your cuspal angle of your posterior teeth, as well as your compensating curve, or also known as the curve of Spee. And your posterior determinants of occlusion are essentially your condyle, the muscles which are attached to your condyle, as well as your essentially your articulatory system. So that's essentially your condyle in three dimensions. And when we're talking about condylar angle, it's not only in the axial, but also in the coronal and sagittal planes. Your intercondylar distance, your immediate side shift, which I'm going to discuss about in a second, as well as your progressive side shift. So let's have a look at lateral excursion. And lateral excursion is when you're biting together and you decide to grind your teeth to one side. So when you're biting together into intercuspal position, and then you try to grind your teeth to one side, you have done a lateral excursion. Let's say in this scenario, the patient is going to do a lateral excursion to their left-hand side, so your right-hand side of the picture. So if the patient wants to do a lateral excursion to the left, the condyle on the left becomes the working condyle, and the other condyle becomes the non-working condyle. So initially, the patient makes this kind of a small jerky move toward the left. And if you look at the non-working condyle, your non-working condyle has started to move from, our point of ICP into this initial jerk movement. And as the lateral excursion continues, your non-working mandible further advances toward the left. And it actually creates this like in a further distance, which is called the progressive side shift. So you do have an immediate side shift, and then it goes to the end, and from the end point to the beginning point is called the progressive side shift. Now, if you look at the condyle, the non-working condyle from above, essentially your starting point of your journey to the end of your progressive side shift creates an angle with your axial plane, and essentially that angle is known as the Bennett angle. So when it comes to you trying to transfer dynamic mandibular movements into an articulator, you've got a number of values to transfer, and these values are listed on your screen. So you need to transfer the orientation of the maxilla, you need to transfer your incisal guidance, and also you need to transfer your intercondylar distance, all your condylar angles in three dimensions, essentially, as well as the values for your immediate and progressive side shift. And you transfer all of these to your fully adjustable articulator. Now, just to show you what the articulator has got an incisal pin, and the incisal pin allows you to change the OBD, increase or decrease OBD where needed. And also you've got an incisal guide pin, which is adjustable, as well as your incisal guidance angle, which also is adjustable. So you can see here, you can actually change the angle of your table on number 1, and on number 2, you can also adjust the incisal pin in terms of actually what angle they're coming. Now, if you look at the back of the articulator, you can also see that the intercondyle distance can be adjusted, and you've got several screws which you can loosen and adjust the condylar angles in 3 different planes in terms of where your condyle is moving against glenoid fossa. And you can see these all marks in 1 for your intercondyle, and 2 and 3 are 2 different dimensions of your condylar angle, if that makes sense. And further back on one of your condylar components, you can also see that you can also adjust your progressive and immediate side shift in numbers 1 and 2 respectively, as well as another angle for your condyle. So the way you do it is you have to fill in this prescription for your lab who has got a fully adjustable articulator, and just tell them all these factors of what number of degrees or what number of millimeters. But then obviously you're going to ask me how would you transfer all these figures and numbers to your fully adjustable your articulator. Essentially, the device you have to use is known as pantograph, and there are a variety of different types of it. And we do have this one at the dental hospital, and I use it probably twice in my life. And just to give you an idea, this is my iPhone on top of the pantograph, just to give you a kind of context into the size of the box. And then when you open the box, you will have 3 different layers of instruments all set within. And I made a video and I posted it on YouTube, whereby you can see how this pantograph is used in full depth. But for the purpose of this lecture, I'm simply just essentially putting it fast forward so I can walk through some of the bits with you. So essentially with your pantograph, you do have a Facebow, which goes to your maxilla, and you've got a Facebow, which goes to your mandible. So you've got this computer, which goes behind the patient chair, and then you've got your apparatus, whereby you put it on the patient's top jaw initially, and then the mandibular bit. As you could see, there was a clutch which you fill in with a registration paste. It goes over the patient's mouth, and you do your mandibular Facebow. And then when everything is alive, you change your side components into the stylus and the digital recorder, which then goes to the computer, and the computer goes into your laptop, which also gives you a foot pedal. So essentially, you then ask the patient to do different positions, and as they do different positions, you acknowledge by pressing on the foot pedal. So essentially, you repeat every procedure, lateral excursions, protrusion, for 3 times. So essentially, it took me around an hour to set it up, around half an hour to record all these parameters, and then another 45 minutes to dismantle it. So it's a good 2 hours, 2 hours, 15 minutes appointment. It's very long, and it's very involved. So essentially, if you want to watch the full video, it is available on YouTube. I think if you just put pantograph, there are only a handful of videos in the world, and the one which has got the most views is mine. So go and actually watch it in depth if you're interested. The question is, would you ever use it? And in all honesty, use it in complex cases. And when I say complex cases, actually complex cases for a specialist. For you guys, it's probably very complex cases. And for example, patients who are severe class 3 and the guidance is purely on their 7s or 8s, if that makes sense, or they do have significant deviation from the normal anatomy. For example, this was a patient of mine who came in, had a number of indirect restorations done in her maxilla, and then I had to restore her mandible with and the patient had denture gyrus imperfecta. So I asked the patient to bite together so I can take my photos in ICP. And it looks like she's got her mouth open. I was like, can you close it? And she's like, I'm closing. And essentially, this is what she looks like. So significant skeletal open bite, and then the posterior teeth only providing any guidance, if that makes sense. So in this kind of very, very tricky cases, obviously, as a general dental practitioner, we don't expect you to handle them. A lot of times it's really actually going to refer such complex cases to us, specialists, to help you with them. So what can they, what can you guys then use? So probably a fully adjustable articulator is a little bit over the top for somebody at the general dental practice level. So let's just come down to semi-adjustable articulators. And this is an example of one, which you can also find at the dental hospital. And let's just have a little look at the anatomy of the semi-adjustable articulator. So with semi-adjustable articulator, as you can see, there's an incisal pin, which you can still move it up and down and change the OBD with it. And also at the back, you do have a few screws, which you can to some extent change the condylar angles a little bit, but you don't have all the full functionality of changes that you had in the fully adjustable articulator. And again, you can see that you can essentially loosen those screws in the image and change the condylar angle. And essentially, there are, like, in 2 different variations you can do. And also, you've got a side shift. So you don't have like progressive and immediate, like, you just have got the one value. So which means if you've got a patient who's got a massive immediate side shift and then to progressive, you kind of actually cause potential interferences if you're purely relying on your articulator. So then the question is, what do you need to transfer to these articulators? So things you need to transfer is the plane of maxilla, which can use a Facebow. And also you have to do your incisal guidance. And with your incisal guidance, you can make a custom-made incisal table, which most of the time is copying your existing guidance or your provisional restorations in place. And then in terms of your posterior guidance, you have to take some lateral bite registrations. So just to tell you how it works, let's say, for example, you are going to make a patient 6 crowns, and you want to make sure that they are following what your provisional crowns have got. So let's say a patient has got worn down teeth, you decided to, like, crown the anterior maxillary 6 teeth, and you prep them based on the wax of you've planned. You already got either chairside new temporaries based on your wax ups, or you have taken impression, either digital or analog, and have got some provisional, either composite or PMMA crowns that you would like to try for a couple of months on the patient before you commit to your real ones. And then the patient is happy and you've adjusted the occlusion, you want to just copy this one into your future ceramic crowns. So the way it works is, so you take your Facebow, you take your alginate or silicone impressions of the upper and lower in the confirmed provisional situation, if that makes sense. And then you send them to the lab and ask them to make a custom-made incisal table. And what they do is, as you can see in the pictures, they use a custom-made incisal, essentially jig. They put acrylic, and then once they mounted, obviously the casts are mounted, and then they move the pin based on the guidance which is being produced by the cast. And as your acrylic sets, it will create a platform, and then they will put this actually platform in your lab box, and then you can store it safely. And then when you've done your preparations and you send your new final impression of the maxilla in this case and your new Facebow, they mount your new impression against the existing lower, and they put the custom incisal table there. And they know that, like, when they're making the new ceramics for you, as they move the articulator, it pretty much mimics your existing occlusal to quite a greater degree. Wouldn't be perfect, but with a greater degree. But also you have to transfer your condylar or your posterior guidance. And the way you do is, as well as taking a ICP intercuspal position, you also have to use 3 bits of wax. So you warm them, you put them on the patient's mouth, ask them to gently close, and then grind to one side and stop. You cool it down, you take the wax out, you just write down whether it was left, right, etc. And you do this for the other lateral excursion, you do that for protrusion. So essentially, you send the lab 4 records, your ICP, which can be done in wax or a bite registration paste, as well as your 3 dynamic records, which are your lateral excursions, left and right, and protrusion. And when you send all these records to the lab, they will loosen up your articulators condylar parts, and they put different 4 records, and they keep tightening gradually your components until they realize that all your records fit quite nicely into the articulator. And they take a note of, like, whatever they set up on the articulator. So every time the lab work goes back, they can actually readjust the articulator based on your condylar parts. Now, Facebow. So your Facebow is a device that transfers the plane of maxilla in relation to an arbitrary axis of rotation for you. So essentially what it does, it tries to mimic exactly how your jaw looks like in the patient's mouth. Again, if you do go onto YouTube, you can actually watch the video that we made on how to take a Facebow record. And essentially what you need is your Facebow kit. We do have dinar Facebow on the clinic, and you do have a Facebow fork, and you can use either a bite registration paste or some wax. This is your Facebow jig. And also you've got your ruler to measure your 43 millimeter of incisal pin. So ideally, you should have already had some primary impressions, so you can test that your Facebow sits comfortably on an existing cast. But if you don't, there's not a problem. So you can take your primary impressions and Facebow at the same level if you know what you're doing. So here we're just checking that your Facebow fork is a good size for the cast or for the patient's mouth. And then you're just going to either use a bite registration paste or just soften up some wax in order to pick up an imprint of the maxillary teeth in your Facebow in a minute. And once you've laid the wax nicely and you have removed any excess, you soften the wax, and then you go in the patient's mouth. As I said, the whole video is available on YouTube. Please go and watch it, because you also have got commentary to explain how it is done. And what I would do is I will put a link to this video also on your Blackboard, so you can go and watch this video in detail. So you might say, oh, Prof, Reza, it's too much. Let's just see if we can just make my life a little bit easier. I'm very confused with all those lateral excursion bites and everything. So in these cases, you might be able to use an average value articulator. An average value articulators are very simple. So what they are done is they've made these based on an average value of all the condylar and incisal figures for an average population of several thousands of people. So essentially, the only thing you have got access to change is your OVD by moving your incisal pin up and down, but you can't do anything with the condyles. So it is what it is. So the question is, do you need a Facebow? And to be honest, yes. If you take a Facebow, you would at least have got the maxillary plane transwelled well. So if you're doing essentially more than 2 single crowns, I always suggest that you definitely do a Facebow. And then you go to the simple hinge articulators, and they don't replicate anything, if that makes sense. They're just very simply 2 bits of metal, whereby you just put your casts, and they can come in different variety of force. But what is really important about the simple hinge articulator is they can only produce intercuspal position. You cannot change OVD, you cannot reproduce dynamic occlusion. And to be honest, then last year we do not have any simple hinge, but then you go to practices, and if you're just doing, for example, a single crown and a premolar, that's probably what they use for you, and just mount it on. And then finally, you come to the handiculator, whereby you just put the cast together, and your hands are your articulators. So now that you know everything about the articulators, let's go back to the quiz we had at the beginning. So what type of articulator do you think this one is? So let's have a look. So it looks like in terms of condylar movements, you can move a couple of things. So you can have condylar angle in 2 different planes done, but then looks like you can only move the pin up and down, and that's it. So you can't really actually do much more. So this becomes a semi-adjustable articulator. If you guessed it right, well done. Now I'm just going to very quickly cover occlusal disharmony, and essentially I'm going to start with interferences. And interferences, essentially, there are tooth-to-tooth contact that prevents a smooth mandibular movement. And if so, essentially, it's good to know that the posterior interferences generate quite a high level of forces, and they may lead to fracture of the tooth or your restorations. And by Ramford, apparently, they might also trigger parafunctional activity. How true that is, this is a lot of debate on it, if that makes sense. So when it comes to tooth-to-tooth contact, if you look at normal function, in a day, a normal person would have a tooth-to-tooth contact of about 4 to 10 minutes per day, which is going to put around 20 to 40 pounds per square inch of force on your teeth. And the majority of the direction of the force is vertical. Whilst when you're looking at parafunction, you're looking at 4 to 5 hours of tooth-to-tooth contact, which can put in excess of around 300 pounds of force per square inch on your teeth. And oftentimes the forces are horizontal rather than vertical. So essentially, by pure definition, a physiologically acceptable occlusion is one which is free of patient complaint and recognizable pathological conditions observed by the dentist at the time of examination. So if you don't fit this criteria, then you're looking at occlusal disharmony. So some of the signs of the occlusal disharmony is excessive tooth wear. You may start to see fractured teeth and restorations. You start to see debonding of the crown and bridge work, and you can't figure out why. A lot of time in these kind of cases, you may just get mechanical failure of restoration. Teeth might become mobile because of excess amount of load on them. And you may also, if you do have gingival inflammation, you end up with having localized bone loss. So here is a patient of mine with excessive tooth wear, and this gentleman, as you can see, has got very strong masseteric muscles, and this is what he had done to his teeth. And apart from the ones which are protected by crowns, they were quite worn down. Here's another case whereby we had tooth wear. We tried to increase the OVD and stabilize the occlusion using a combination of composite restorations and some provisional dentures. Now, further down the line, unfortunately, the lower teeth fractured. So we then ended up adding the 2 lower incisors into the acrylic dentures. And then further down, we then changed the acrylic dentures into chrome. And this is actually how we changed. things, and then the composite changed into ceramic restorations in the maxilla. But then a year down the line, the patient unfortunately chipped the lateral incisor, and this is just when we then re-examined the occlusion, we realized that we had completely transferred the lateral excursions from any of the posterior teeth and put them on the lateral incisor. It was simply too much for the ceramic to carry on accepting all those lateral forces, and it chipped. And sometimes if you do a periodontal, poor periodontal bone support, excessive forces can lead into movement of your teeth. This is a young lady in their late 20s who had localized essentially molar incisor periodontal pattern, and you can see the central incisor used veneers, and they started to drift toward buccal. So it took me a while until I managed to actually obviously stabilize her perio and then fitted her with some more cosmetic restorations, as you can see in the picture. But most importantly was we managed the perio and then managed occlusion before I managed to actually get to these results. Also, on top of all the things I mentioned, you may also start to get post-cementation pain or discomfort, and you may start to have muscular pains and TMD symptoms if you're not managing occlusion well. Anyhow, so take-home message is that select your articulators based on your needs. In majority of the cases, you will need a Facebow, and be very clear on occlusion. So that brings me to the end of this symposium. I hope you enjoyed it and have a lovely day.